moderator for the session. I guess all are familiar with him by now. So I think we can start with few case presentations. We have Dr. Shantini and Dr. Meenakshi taking patient stories today. And if time permits, Dr. Sunil will be showing some patient stories and we will be having a discussion. Thank you once again for all joining us. Dr. Sunil?
Yes, Theo, thus Rajlakshmi.
Yes, sir. We can hear you.
Theo is here.
Dr. Theo haven't joined, sir. I will message him if he's able to join us.
Okay.
Sir, like we can start with Dr. Shanti's presentation first. Sripriya, can you show the presentation? Yes, over to you, Dr. Shanti.
Hello. Good evening.
Yes, ma'am. Yes, ma'am. We can hear you.
Okay, thank you. I am presenting a case of 50-year-old male, and he came to our clinic with the pancreas tumor of the left lung. Okay. Then he came with pain left shoulder, neck, and upper limb of 2 weeks duration. And at that time, he had weakness of the left upper limb, chest pain, and breathlessness. Then regarding the history of the illness, he was diagnosed with the CA lung for the last 1 year and all, and he had received chemotherapy and radiation, and now he came with the pain over left shoulder, neck, and upper limb, and it was a shooting type of pain, and with a score of 10 by 10, and that pain was aggravated by movement, and he had poor relief with the analgesics that he was getting. Then pain over the left side of chest was catching type, no radiation, and it was increasing with cough and with a 6 by 10 score. And he also had exertional breathlessness of NYHA class 2 and a weakness of the left upper limb, and he was unable to lift the limb, supinate or pronate the forearm. On examination, he was a 48-year-old, 48 kg, he had a 48 kg weight, was very much emaciated, pale, and had clubbing. And there was a swelling over the left supraclavicular area, hard, irregular, and 4 into 5 centimeter in size. And the chest air entry was decreased in the left anterior areas, and there was no added sounds. And upper limb, the color and temperature of the left upper limb was similar to the right, but there was wasting of muscles, and muscle power was only grade 2 to 3. Other systems was normal. And regarding the investigation and treatment part, his hemoglobin was only 8.2 grams per deciliter, and liver function, renal function tests were normal, ECG was normal, chest X-ray had mass upper lobe of the left lung, and some COPD changes. Then CT thorax showed left upper lobe mass, mediastinal and chest wall infiltrates, and narrowing of the left bronchus. Then regarding treatment, he had received radiation and chemotherapy, and had got analgesics like tramadol, paracetamol combination, and amitriptyline. And during the first visit, that we changed to morphine 60 milligram per day, then along with bisacodyl, and paracetamol, the supply is always 500 milligrams. So we were giving 500 milligram 6 hourly, amitriptyline 25 milligram HS, and for the breathlessness, Dexona 4 milligram for 3 days, and along with the Pando. Next slide. Hello.
We have changed
My
psychosocial aspects.
Oh, okay. Sorry. Regarding the psychosocial aspects, he was a very much cheerful and a person with a positive attitude, and there was a good family bond among them. And his wife was a homemaker, and elder daughter, she was the most supportive person of the family actually, and she had discontinued her studies and started working. Younger girl had hypothyroidism and she was weak in studies. Then relatives were very much helping in every aspect. They were very much supportive and concerned and they were ready to supply anything like oxygen cylinders, medicines, and also financial help. Neighbors stood with them in all throughout. Then church also actively involved, and Pallium India telehealth services team did immense help for him. Like Sir made video calls, then later, as per need, video calls were made and supplied. Then methadone was supplied, and did counseling during end of life time, and also bereavement support after demise of it. Then regarding the pain medications, initially we started tap morphine 60 milligram per day along with gabapentin 100 milligram BD and amitriptyline 25 milligram HS was given. This gabapentin was changed to sodium valproate 200 milligram per day due to poor affordability. Then later, this morphine we increased up to 110 milligram per day, and he developed some features of toxicity, uh, fearful dreams and all with unsatisfactory pain relief. Then the oncology people were gave the opinion that he had a highly virulent type of tumor, and it was fastly spreading, and it was poorly responding to treatment from their side, and it was so extensive. And then telehealth service consultation again was done, as he was repeatedly asking for injections to relieve the pain. So the interventional pain management was discouraged because stellate ganglion block we can't give because of the vascular structures nearby, and so it was not much. It was discouraged. Then so methadone was considered. Then methadone 2.5 milligram per day started after ruling out any ECG abnormalities, and this dose we increased up to 15 milligram per day. Then during this time, morphine we slightly uh, reduced the dose to 10 milligram BD and SOS. But his disease progressed, and he developed newer lesions, and then slowly he went into end of life. He developed on end of life delirium also, and this delirium we managed with the haloperidol 2.5 milligram HS. Then, because to treat the hyponatremia, dehydration, and all, he was admitted in the oncology ward for 2 days. But he was insisting to be at home. So then he was shifted to home, and then oxygen was given, home oxygen, because his relatives were very particular that he should be given oxygen, and they supplied cylinders also. So oxygen was given when they noticed a drop in saturation. So main concern for this patient was effective control of pain, then management of end of life period at home as he was demanding for that. Then role of oxygen, IV fluids, etc. in this stage, because his relatives, nearby people, and everybody will be giving some opinion like why you are not giving RT feeds, or why IV not glucose is being given like that. So then another concern is need for hospitalization at this period during end of life. So the summary of my case is a 50-year-old man, fish vendor with the pancreas tumor left lung causing brachial plexopathy and came for management of pain. And actually he came for interventional relief of pain, which we had to defer. Then he developed toxicity to oral morphine and was given methadone. Then he had a very much virulent, extensive the type of lung cancer with new lesions over the appearing over scalp, cervical vertebra, sphenoid bone, orbital fossa, and all these were poorly responding to the treatment. Then later he went into episodes of end of life delirium, then wanted to be at home during his last days, and had good psychosocial support from relatives, church, local health department, and Pallium telehealth services. Then bereavement support also was provided by all. So discussion points are availability and titration of methadone, because for him, when we started methadone, but his disease progressed. So it was very difficult to titrate the drug. Then another problem whether we can't say like that, because it is not freely available, and all the methadone the drug was couriered from the Pallium India, so that was reaching them properly. Then the role of interventional pain management in such cases, because patients come for that, and how to go manage it properly. Then how to support the family during end of life, because his wife, his children, all were very much concerned. Because when it come to the last days, it was not very easy. That is, frequently the girl will be, his daughter will be calling us. Whether they wanted him to live one day more, they wanted him to live few hours more, and like that it was. What can we do? Even at the last, during that time also, she was asking, "Can we do something? Can I bring her to the hospital? Anything can be done now." But he was, his saturation was dropping. He was slightly going off. Then still at that moment also, they needed how to manage that situation in such situations. Okay, thank you.
Thank you, Dr. Shanti. So, regarding the availability, I think I would first talk. Methadone is now available if the institution has an RMI status. So anybody with a recognized medical institution status can get methadone. There is you need not have any other license or anything else for getting that, and it is available in some places. So if you need to get methadone, there would be some local agencies. And in India, only one pharmaceutical, Rusan, is making methadone. So you can get in contact with local methadone supplier. In Kerala, there is one agency at Kochi. So availability, I think it is not a problem. I think rather than availability, it is the hesitance to use methadone. And that's what I think is the main factor. Yeah. So I think somebody else from the participants can talk about titration of methadone.
So in regards to the titration of methadone, I guess one question I had was for the initiation of using the 2.5, was there a particular reason why that dose was initiated at first?
Hello.
Hello?
Actually, this patient, when I had problem in managing, I contacted Pallium telehealth services, and Rajagopal sir made a video call with this particular patient, and sir suggested this dose. So then his sir's suggestion was to start with a very small dose and taper off the morphine gradually. That was the plan. But the disease was progressing, and we could upgrade it only up to 15 milligram BD, and by the time he became very bad. Like.
Okay. Yeah, so I mean, I don't think that is necessarily wrong, right? Because if we're doing a more slow transition, oh, I guess there is a question that the audience is asking. After starting an increased methadone, did patient find pain relief?
He had pain relief for few days, like some improvement, but this disease was so very much virulent, and it was spread. He was not his general condition. Everything was becoming bad. So that titration part, I don't know whether it was very correct, or the disease progression was the real problem for him.
Okay. So, I mean, in regards to doing a conversion with the methadone, right, based off of his age and his opioid requirements, I think that doing that conservative approach is okay too, doing that slow conversion to the methadone. Alternatively, right, if we used the white paper consensus to do a conversion rate, that 110 milligrams per day of morphine would be 11 to the methadone. So that could have been a potential alternative starting dose per day, right? So that could be 5 mg BD. That could be tried in the beginning to see how they respond, and then going up on the dose increase. But that's one method to do in regards to
So, sir,
conversions.
will you suggest any hospital admission or something when we start methadone? But is it needed?
Hello?
Hello, any admission and monitoring? It is not needed, no. When
So
we
it depends on what the goals of care are. If there's any other comorbidities or risk factors for that might elevate someone's risk for QTC prolongation, right? But if we don't necessarily have that information, I think this approach of going more conservative until you have more information is reasonable as well. And in regards to interventional treatments, what was options that they discussed again? I didn't hear that part.
option possible is, sir, in stellate block. Because
Okay.
for that that swelling, then nearby structure, major vascular structures are nearby, no, so that we didn't go for it.
Right. So
We are not, to be frank, sir, routinely we are not doing any interventional block. We are planning to start, whether we are thinking in that way only. So
yeah, and I agree with that. Given the locations of the pain and the diffuseness of symptoms, interventional pain would be somewhat limited on this because the areas that can be utilized and the interventional, like nerve blocks, to be considered is somewhat limited with options, and there it's hard to say if he would have necessarily responded to these interventions as well.
then another thing is, he came with this upper limb pain, but later he developed the one orbital mass, then swelling over the sphenoid and over the scalp. So just giving some block for the stellate, it won't be that much effective also, no? Because the pain was becoming generalized, like more and more generalized. So why to concentrate on one particular point also?
May I make a point here? This is Dr. Meenakshi.
Yes, please.
So, in terms of interventional pain management, you said it was deferred due to severity of disease. I mean, we've had a similar patient, precisely. In fact, I think only the site, the side of the problem was different. Same pancreas tumor, and wasting of the limb. And what we find is if we do the intervention early on, it cuts off the vicious cycle of pain and chronic pain, and more changes earlier. So our case was also similar and close to vascular structures, but again, our palliative care team is not trained to do blocks. We have the interventional pain team who has done a team of 2 members who have undergone training to do interventional pain management. So they did perform a stellate ganglion in our subject, and patient had very good relief for 3 months, and in fact came back asking for one more block when the pain resurfaced after 3 months. If we I mean, earlier on, like for example, when he had the pain, it would have been a good idea to, I feel, could have gone ahead with stellate ganglion block at that time, and then later on, as you said, the other areas were becoming painful. The sphenoid, the scalp. Um, that's the point I wanted to make, and. For the sphenoid and scalp, etc., I'm sure the oncologists would have given bisphosphonates because all bone secondaries. I'm assuming that bisphosphonates was used.
Not sure, ma'am. Thing is,
Okay.
Your center, you were giving alcohol-based blocks. Is it like that, ma'am? Or local?
No. It was only local anesthetic.
Okay,
So
okay.
because again, close to vascular structures, they were
Okay.
diffident to do a neurolytic block. So they just gave actually a local anesthetic, small volume, along with some steroid. And a patient did pretty well, and they came back 3 months later for another block, went for another block also.
Okay.
After that.
Okay.
So
we'll try that. So many patients are coming. Even now, patients are coming.
Yeah, but then again, as I said, it is not my team who performed it. We are not trained. So we had the luxury of another team who's specifically trained for that. So I think, given your scenario, the diffidence in doing it because you don't have training is not a bad thing. It's good to know one's limitations and act in the best interest of the patient. So I appreciate that very much. But you have also correctly identified that that is something which could have been done. So,
yeah, I always feel like that. But still, basically, we are anesthetists, so we can do UST based.
Exactly. Yeah.
So we are planning to means some hesitancy and our routine work, and this comes. So to begin with, that is, we have to start it. That's it.
Yes, absolutely. Thank you.
How to support this family during end of life? I'm sure there are many of you who has faced a similar situation, and how do you support a family like this? So this patient wanted to be at home, and he died at home. So Dr. Sandy is asking how to support a patient like that at home during end of life. Can anybody?
Actually, I had a question regarding that. I wanted to know what was done with methadone at the end of life, whether we went with methadone or whether we chose parenteral morphine, or what happened exactly. I kind of missed that.
Actually, he continued methadone. Then morphine also he was taking. Then another problem was all were contributing, like oncology people, when he got admitted, that they will be giving something. Some confusion was there because each person will suggest something. Then the family also, they went to some center in Kochi also, Ernakulam. So from there, some other suggestion. So some confusion was there. But methadone she was coming, taking, and then dilution and all. She used to come, his daughter used to, I think methadone they were taking, morphine tablets, SOS basis he was taking, like that. It was not never denied, like through till end of life he was getting methadone.
And how was the end, madam? Like, I mean, was it like somebody was making video call? So I mean, from telehealth. So
Yeah.
was the patient struggling, dyspneic, or agitated? Was I mean, you said delirium was there, but generally was the end? I mean, appearing peaceful, or what was happening? Was there some team visiting them at home?
That is our local palliative team was there from our medical college. A group of people had doctors had gone. Then
Okay.
another thing, from actually their house is bit away from our medical college. So one local center from the primary health center, palliative people were visiting. Then from the church, some people were visiting their relatives, like that. Everybody will be having some opinion, and actually all were helping them. He was not struggling. Actually, saturation, according to her, saturation dropped, and at that time some breathlessness was there, but it was not very painful for them to watch like that. What I could understand.
Did you not consider palliative sedation? Because I mean, you were having a lot of distress calls from the family. Can you do something? Can you do something? So this is just my question. I mean, did you at any point think about palliative sedation? And the faculty could also, I request the faculty to tell us, like, if the patient is on methadone and I want to start palliative sedation, should I withdraw the methadone summarily and just switch to morphine, or what should what should be the way to go in this scenario? Thank you.
Theo, your experience.
So, I mean, on the points of palliative sedation, right? It would be a lot of conversations with the family to explain what that necessarily would mean, and also with the patient, right? If they have a true understand of what palliative sedation would be, and I think the audience is asking what is palliative sedation. So palliative sedation is essentially utilizing medications to sedate the patient or have them essentially continuously be asleep because the symptoms are so severe that they're difficult to manage. And this would be, can vary between medications that are used, but this would essentially be anesthesia for the patient until the end of life. And usually these would be pretty significant or substantial scenarios before we would consider this, right? And this would be something that the patient would need to consent to. And having a big discussion with the family and making sure that all members are understanding what exactly is going on with this. And communication is really key on this because this can easily be confused with euthanasia, right? Especially if things are miscommunicated. Since this concept might be a little bit more abstract for some patients. In regards to the setting which palliative sedation would apply, from my experience, usually it is done in a hospital setting. I'm not quite sure about that use in home setting or palliative ambulatory care setting. But usually it could include things like adding on a morphine infusion or drip, on top of a Ativan or midazolam infusion as well, and adjusting and titrating to have the patient sedated, but still not necessarily causing harm to the patient.
This is Dr. Theodore from
Thank you, Theo. I think if the patient is on methadone, it is sure that we need to continue methadone or some other opioids. But if it is methadone, I think it would be better to continue with methadone. If patient is unable to take orally, give the concentrated solution parenterally, and start the patient on palliative sedation. By now, we are you can give midazolam, and sometimes patient might have excitation due to midazolam alone, and also due to opioids, including terminal delirium also. So we need to use haloperidol, but now if that condition arises, we need not look into the QTC prolongation effect of haloperidol. I think we will be focusing mainly at comfort of the patient. If you are unable to give methadone, then because the patient was using some opioids for last few weeks, so we have to continue with opioids. So that's why you need to continue on the methadone or injectable morphine or something else.
This is Dr. Theodore from Cancer Institute. May I add a point regarding how to support the family during EOL? During the description of the case, the daughter was repeatedly asking, can we do something for him? Can we do something for him? So I think communication is a key in the end of life management of these patients. It is natural for the family to always go back one step. They'll always go one step backwards only, despite understanding the situation very well. And this is where all our communication skills come into play. It is our responsibility to repeatedly reiterate that the goal, focus them regarding the goals of care, tell them that the patient is comfortable with the medication, no pain, and all these things, and they are not going to benefit by hospitalization, so that the family will be satisfied that they have done everything for the patient. So the bereavement will be smooth. That's it. Thank you.
Yeah, thank you, Dr. Thanpal. Another thing which we have to understand is usually the caregivers who are anxious, they will continue to ask the questions, probably the same question they will continue to ask. And what we have to understand is that they are under stress and they want to talk something to somebody. So I think the best thing would be to listen to him, and if there is anything to address that problem. So this is a very common situation that usually happens when we admit the patient. Even if we talk to them 5 times, 10 times, they will come and ask the same question again and again. It is not because they don't know. They want to ensure that their loved one will be comfortable and they will get some support. So that's all what they want. Anybody else has any more
this
points?
home oxygen therapy and all? Because
Okay.
one relative was very much particular that he should be on oxygen throughout, and that person was ready to supply oxygen cylinders and like that. Then that part was little difficult to handle.
Yeah, this is always difficult because usually what happens according to our culture, whenever a patient is being admitted in a hospital with breathlessness, everybody will get an oxygen mask. So breathlessness is equal to oxygen in our culture. So everybody will expect that that should happen. But then even I think the patient will can have some benefit if the oxygen saturation is below 88. But the problem is that even patients with less oxygen saturation, they may not get any symptomatic relief with oxygen at all. So what we can do, if particularly if the oxygen saturation is low, um, you give an oxygen trial. That is, give oxygen at least for 10 minutes and see whether the patient is having any symptomatic relief. So if the patient has symptomatic relief, that is reduction of breathlessness, not by looking at the saturation. You have to ask the patient, do you have any relief with oxygen? If the patient says, no, I don't have any relief, probably the patients will be taking up the oxygen mask and pulling up it every time. That's what we usually see. And we can show it to the family member also. See, the patient is pulling up the oxygen mask because it is very uncomfortable. And when you ask the patient, no, it is not helping me. So these are clear indications that it is not helping. So uh, even if you start oxygen, you have to tell the caregiver that this is only a trial. We will give oxygen for 10 minutes and we'll see whether it makes any difference for the patient. And if the patient is comfortable, then we will continue. Otherwise, we need not continue because it is even going to make more problem for the patient. Something, a mask is a communication barrier, and in addition to that, it will also be suffocating for the patient. That's why he or she is pulling up the oxygen mask every time. So I think this should be our the way of communication. Anybody has any more points? Shripriya, if there are no points or comments, can we move on to the second patient story?
Dr. Meenakshi, would you like to present from your end, share the screen from your end, or can we do it from our end?
No, I'll be happy if you could do it. Actually, I'm logged in on my phone, so
Sure, ma'am, sure.
thank you.
Ma'am, you can start your presentation.
Yes, good evening, everybody. I'm Meenakshi and I work at Cancer Institute. Yes, go on to the next slide, please. Yes, my patient is a pediatric patient. Let's call her little N. She is 2 years old, 2 years and 3 months old, female child. Her diagnosis was that of rhabdomyosarcoma of the left orbit, and she was diagnosed in late December 2020. She had been treated elsewhere, and she came to our institution on 7th of August 2021, having undergone enucleation of the left eye in the month of January of 2021. Next slide, please. Palliative care referral was sought by the medical oncology team on 16th of August, pretty early referral. And the child actually I saw her in the inpatient facility, and she had a swelling of the left eye, and the swelling had been progressively increasing since 7 months. So she had the surgery in January, and thereafter, quietly the swelling of her eye had been, the orbit was getting filled up with a soft tissue lesion. So she was crying often. That was one of the complaints. She was very agitated. She was feeding very poorly. Sleeping was very disrupted. She had started constantly handling her eye, and that was causing some abrasions. And the mother also gave the history that the child used to bang her head against the bed, and the mother felt that it is due to pain. Uh, Child also used to indicate that it is due to pain. She was verbal with her mother at least. She wasn't talking much to the doctors. Uh, the primary caregivers was her mother, and the child used to all the time cling on to her. I mean, she would not leave her at all. Mother also reported that the child had loss of appetite and was pushing away all the meals or spitting it out, but actually had no vomiting or constipation. When I examined the child appeared very small for her age. She was very dull and irritable. She was obviously in severe pain. According to the FACES scale, it was almost, I mean, could go up to 10 out of 10, but she wasn't crying at that time, so I scored it 8 out of 10. Uh, Her left orbit had a large exophytic mass, 4 into 5 into 6 centimeters in size. It was fleshy, angry looking, and red, and it was discharging mucoid fluid. All the time, the child was trying to wipe it off, and in the process, hurting it with her nails. She weighed only 8 kilos. An average weight for a female child in our setting would have been 12 kilos. Next slide, please. So initially, I started her on morphine, 2.5 milligrams every 4 hours, and syrup lactulose, because she being less than 6 years of age, I did not want to give her a stimulant laxative. And syrup lactulose 5 ml at night, and syrup paracetamol 3.5 ml. This is the single strength paracetamol every 6 hours. She was on a regular follow up in the ward, and one round of chemotherapy was administered, which comprised of cyclophosphamide along with ifosfamide and adriamycin. Pain control was poor, and the tumor was still increasing. At that point, I discussed with the medical oncology team. I was the primary physician from my team who had been following her up. I live close to the children's wing of our hospital, so I used to follow her up pretty often. And so I was discussing with the medical oncology team that why don't we give her a round of steroids. We also consult the ophthalmic team at a different hospital to see whether there was something else we could do, because we had not primarily done the surgery. And I was also asking them, why don't we try radiation, because even if it doesn't treat the primary cancer, at least rhabdomyosarcomas are not known to respond to RT. They're more chemosensitive. So, but at least if we could get a reduction of the size of the lesion, at least cosmetically, and for pain, it would be better for the child. So that was ongoing, and morphine slightly. I mean, we were escalating it every visit. I was escalating it, and we had reached 20 milligrams every 4 hours over a period of 1 month. And I had also added syrup ibugesic plus, which is ibuprofen with paracetamol, 2.5 ml TDS thrice a day, because I thought some anti-inflammatory, while we decided about the steroid, because with the counts and the chemo ongoing, the oncologist wasn't very excited about the steroid at that point. Though subsequently we did do a pulse of steroid as well. Next slide, please. So how the illness progressed was we discussed with radiation oncology, medical oncology, and anesthesiology that we would attempt palliative radiation for the child, and she underwent several sittings of radiation. Every sitting required the child to be anesthetized. Mold had to be made, the mold had to be placed on the child, and she had to undergo the radiation cycles. It was initially there was some resistance from all teams saying that this is cumbersome, this is going to be difficult, and but I was very adamant on this point. If it was going to give her some benefit, we should go for it. And I mean, reluctance because of the a logistic nature. I mean, transporting the child every time from the pediatric wing to the anesthesia. I mean, to the radiation suite, and actually administering anesthesia should not be considered as a deterrent to administering her therapy. Actually, the pain and the tumor size decreased dramatically. In fact, after that, it was flush. It not only became flush with the surface, in fact, it receded inside the orbit completely. And morphine, we could taper morphine and stop it by early November of 2021. So we started on 16th of August, and by early November, the tumor had gone underneath completely. Then her chemo was continuing, but she was admitted on 29th November with severe pain, bilateral upper limbs and lower limbs. She was irritable. She was lying in the lateral position, refusing to sit up in bed. Of course, she wasn't standing up at all. So, the differential diagnosis that the oncology team was uh, dabbling with was one of viral arthritis, or probably there was progression of disease. Uh, then we restarted morphine, having experienced morphine before, and her good response to morphine. Subsequently, we restarted the morphine, we restarted the ibugesic, and again started ramping up the morphine. From 2.5, we climbed up to 15 milligrams again. Again, in a week or two, actually, the child became ambulant. Presumably, this was some sort of a viral arthritis, and then again we started tapering morphine. So 5 cycles of chemo, ifosfamide and idriamycin were given, but this time she came back with persistent fever. The counts were normal, but there was a fever which required us to, which would not respond to ibuprofen, it would not respond to paracetamol. Naproxen was the only tablet which was helping her reduce the fever. 250 milligrams twice a day was being given. So the oncologist decided to do a PET scan, and that showed progression of the disease. Uh, but the parent, the mother, was actually, she was a single mother. Um, she was very adamant. She said no, she has been doing well with the chemo, and you just have to give her one more chance. And the medical oncology team also relented and gave her the 6th cycle of IA chemo on in Jan 2022. And then they said that they would be following this up with oral metronomic chemotherapy, which is basically etoposide and cyclophosphamide. I mean, this was the last ditch effort for trying to get the disease under control. Next slide, please. So then the fever bursts kept on continuing, and every week the patient would get admitted either for fever, there would be diarrhea, there'll be some poor feeding, and in and out of hospital the next 3 weeks is what was happening. And finally, medical oncology said, we are calling it a day, and this is going to go back to palliative care for only supportive care until end of life. So the mother was repeatedly counseled by our team, the medical oncology team, the psycho-oncology team, and her social background was such that even hospice was heavily recommended. However, the patient, the mother did not take up that option. Morphine was again on the rise, and we were slowly back to 15 milligrams of morphine every 4 hours. It comes in the following slide, and but the pain control by end of February and early March was inadequate, and somehow the mother started complaining that this doesn't seem to be working anymore. And she was admitted again on 12th of March 2022. Child was in pain. She's extremely fatigued. I mean, there was no activity at all. I mean, the Lansky score was 20 to 30%. Uh, Intake was poor, and she had lost control of her neck movements, and the neck had become totally floppy. Again, of course, the child was very irritable, and when the few moments that she was at peace, she was only sleeping. So at that point, the child was on morphine and gabapentin and lactulose syrup. Then we decided to switch her to oral methadone syrup on 14th of March. And having taken 1 or 2 doses, the mother learned how to give it, and child went home on oral methadone syrup. She was only on regular follow up on the phone with us. We used to make both video and audio calls to the mother. Child was very stable. Pain ceased to become a problem, and of course, the child had become very fatigued. There was significant anorexia, cachexia. Just visibly, she had become very cachexic, and in fact, so weak. I mean, everything the mother had to do for her. She had stopped moving in bed completely. There was occasional fever which required naproxen, and finally, the child passed on peacefully at her home on the 1st of April 2022. Next slide, please. I've only put the very recent investigations, the PET scan, which showed us disease progression, and the sarcoma was filling up the left orbit again, but it did not become, the eye did not become proptotic again, and it was also involving the optic nerve. In fact, even within the orbit, you couldn't actually macroscopically see tumor. There was bilateral lung metastasis also. The March 2022 investigations were all normal except for her hemoglobin, which was on the lower side. We, of course, had ordered one ECG before we initiated methadone, and her corrected QT interval was 462 milliseconds. Next slide, please. So the medications in detail. So we were somewhere at 15 milligrams of 4th hourly morphine, and the child was taking 5 rescue doses. And this was a child who used to grab morphine from the mother. If she sees the morphine, she would just take it and just swallow it, even without water sometimes. So she was acutely aware of her the benefit the drug, that this was a pain relieving drug. She was very aware of that. But in the last leg of her life, the analgesia was very inadequate, and the gabapentin we were giving 50 milligrams. It's a 100 milligram capsule. We were dividing the contents of the capsule into 2 divided doses, and she was also on lactulose syrup, which on and off the mother used to give depending on the bowel movements. The naproxen capsule was we were giving 250 milligrams only when the child had fever. When we changed the child to oral methadone syrup, um, what we calculated was 90 milligrams of background morphine and 5 breakthrough doses that she was taking. So about 165 milligrams of morphine per day, and very poor pain relief. So actually, I just used the white paper consensus and simply switched her to 1 ml TDS. I don't know whether that was right or wrong. I mean, it was totally drastic shift. I mean, to 1 ml TDS, and the morphine was only being used SOS. Actually, she did not require beyond the second day. There were no rescue doses of morphine being taken at all. Next slide, please. The psychosocial aspects. Child, of course, was she was not very forthcoming or very active in front of the doctors or nurses. And if she was in pain, she would be quite irritable, but docile. She wouldn't attack or throw things about or hit or anything like that. Social factors. She was separated from her only sibling, slightly older than her. She was 5. She enjoyed walking around the ward with her mother when she was able to do so. She was very, very deeply attached to her mother. Her maternal grandparents were the people who were supporting the mother and the children, but they were not very welcoming. In fact, they had quite openly told the mother that she should finish this business with this child and come when the child passed on. I mean, it was as blunt as that. So that was actually a sore point for the mother, and I think the child also felt very unwelcome in her own home. She was very comfortable actually in the ward. I mean, as far as she was with her mother, she was quite happy. The child had unfortunately lost her father to a soft tissue sarcoma only 9 months earlier. So her mother was, I mean, despite this terrible family history, her mother was very, very protective and very, very caring of her child. Spiritually, the mother was still hopeful that we could do something and make her better, because apparently she resembled her father a lot. Financially, like I said, it was the maternal side which was supporting the child and the family. But all of the child's treatment was within the scheme, one of the schemes that our hospital supports. Some patients who have very poor financials have a totally free agreement scheme, which the hospital supports through other donors. The psycho-oncology team and the palliative care team had repeated conversations with mother for supporting her. Um, Caregiver support group sessions were also done, and the mother was very happy, and she many times expressed her satisfaction about these sessions. The social worker also had arranged for their stay whilst they were not receiving chemo in a care center which is sponsored by St. Jude's. It's called Home Away from Home. Next slide, please. So the main concerns in this case was that towards the end of her cancer journey, her pain had become unforgiving. There was loss of head control. Child was becoming increasingly weak. Um, she had lost the company of her sibling. I mean, the only person she was really socially interacting with is her mother. And she was very unhappy to go home, actually. One of the few children who never liked the word home. So probably she had sensed the social rejection that she was facing in her grandparents' home. Next slide, please. So to summarize, we have a 2.5-year-old little N who had rhabdomyosarcoma of the left orbit with lung metastasis. She had complex pain, loss of head control, and increasing debility. She was spending a lot of time away from her home. She had no interaction with a sibling. She was being raised only by her single parent. Her disease was relentlessly progressing, and once there was no further disease directed treatment, she was receiving only palliative care support, and her health was increasingly becoming unstable and fragile, and she had the end of her life happened at home. She was supported by her mother and methadone and teleconsultations with the mother at constant intervals. And mercifully, I think her end of life was peaceful, and the proof of that was that when she passed on, her mother called up and said, if it was not for your team, she would have died in a lot of pain. So I'm deeply grateful that she called up and told us, because it felt as though, okay, we had done the right thing. At that point, actually, we were quite doubtful whether it was the correct thing to do. We had switched her to methadone. We had sent her home. We were very worried how everything will go. Next slide, please. So the discussion points, I think about this case study would be, we had used a lot of morphine, and I mean 160 milligrams of morphine for an 8-kilo child. I'm not sure how many teams would be bold enough to do that. Second, opioid rotation in the Indian scenario. We don't have very many options. Fentanyl is very expensive, and methadone, again, like we already heard, there's a lot of hesitancy in using methadone. I used an adult sort of formula from the white paper consensus, and just converted her to methadone. I do not know whether I did the right thing or wrong. And I also, after 2 days of admission, I sent her home. I just trusting my instincts. I don't know that was a right move or wrong move. So I would request the participants and the faculty to tell us. The QTC was between 450 and 500 milliseconds. It is a case where we would think twice before using methadone. But since this was an end of life situation, I just went ahead and used it, and there were no other QTC prolonging drugs in her prescription. Um, Whether we should have used other adjuvants in this patient is another question that was remaining. Maybe I should have used some steroids also. But she didn't report any pain and she wasn't taking any rescue doses. Was it because she had become so debilitated and she couldn't respond, or whether indeed her pain relief was good is something which I don't know. Apart from her medications, what I would like to ask the listeners would be what could have been the other ways we could have used to decrease the child's symptoms. Like I said, she wasn't socially interacting too much with us, and what are the other ways we could have supported her mother? Thank you. That's all I had to say.
Thank you, Dr. Meenakshi. So it is always very difficult to manage a young patient, especially when it is a very young child, and it will be more difficult when we have some children who are also in the same age. So this was very interesting to hear. So I would like to get opinion from participants if they have any comments on this.
So, any role for fentanyl patch and for the pain relief?
Can I take that, Dr. Sunil?
Yeah, you can take.
So, I mean, fentanyl patch, the problem with pediatrics is you can't cut up that patch. I mean, how would you convert it? I mean, conversion is okay, you can convert it, but the affordability is absolutely, I mean, this patient was on a totally free agreement system in our institution. And if she was to go home, I mean, who's going to supply her the patch? One Duragesic patch is upwards of 500 rupees when it's only 12.5 micrograms. She's already taking 165 milligrams of morphine with poor pain control. So I did not consider fentanyl patch at all, actually.
Okay, ma'am.
Yeah, I would also like to tell that fentanyl patch, the thing is, it is highly priced, but methadone is very cheap. It is almost comparable to morphine. So, and even methadone has other advantages than fentanyl. So I think here methadone is the choice.
Also, I just wanted to add, because fentanyl patch, this child is having breakthrough paraneoplastic fever all the time. I mean, every day we were giving naproxen. And I mean, this was for months actually. And, with fever happening, I wouldn't be comfortable using fentanyl because I don't know how much is getting released. It will release more once you have fever. And the child was becoming very cachexic, hardly any subcutaneous tissue. I mean, I would be very diffident to use fentanyl. Just wanted to add that. Thanks.
Yeah. Anybody has any comments on the questions?
I want to ask Meenakshi ma'am one thing. How did you and your team manage the psychological trauma of seeing such a small child undergo all this pain and all that? What kept you? How did you manage that, ma'am?
Okay, I've uh, you see, I mean, when you see children, I don't know. This is my totally my personal opinion. Lot of people ask me, how do you manage children? So I've always felt once you give them symptom control, the next minute the child is up and about. There's no dwelling upon, oh God, it's hurting here, this is happening, that is happening. Pain is controlled, or whatever, vomiting or dyspnea, whatever is controlled. They're up and about with their business. They just don't look back. They're always looking forward only. And so they're so comfortable and they greet you with a smile. I mean, it's so gratifying actually. I mean, my own problems are my own to handle. I mean, when I I go into the pediatric ward, I just tell myself, yeah, if you are having a problem, you handle it. But at least be there for these patients. I mean, they're so brave to spend months out of the hospital and be there be there for them. And if the pharmaceutical help, or we should be there for them. I mean, saying that this is difficult for me, I it's an escape route. Yes, it is difficult, but it doesn't prevent us from helping them. No, your difficulty, we have to deal with it. Whatever helps you de-stress, do it, but be there for them. Because unlike adults, in fact, adults are never happy. They're never happy. Pain relief is complete, then they start complaining about their I don't know, their friends, their family, or their finances or something. But you see children, I mean, never. So many kids, I have never heard them complain. Once their problem is sorted out, they just move on with a smile. They're ready to play with you. It's amazing. I don't know, that has given me
Yeah,
strength.
that's a real insight, ma'am. Thank you so much, and lovely presentation, ma'am. You gave us a lot of insights. Thank you so much, ma'am.
Thank you for your appreciation.
Yeah, thank you, Dr. Meenakshi. I would also like to add something to that. Dr. Meenakshi, are you working full-time in palliative care or part-time in palliative care with anesthesia?
No, I have moved completely to palliative care since 1.5 years, but I have been doing more pediatric than adult from 2017. So, yeah, my pediatric palliative care has been on from 2017.
Yeah. I just want to share my experience. When I used to see pediatric patients, some 10 years, 15 years back, 15 to 18 years back, it was very difficult for me to see pediatric patients because I had two sons who is very young. So always I think of them whenever I see pediatric patients.
We lost your audio, Dr. Sunil.
Dr. Sunil, can you hear us?
Am I audible?
Yes, sir. You are
Yes, now, yes.
So I don't know after where did you hear, but anyway, so 18 years back when I was doing my post graduation, I used to see a lot of children. So at that time, I also had I have one son who was in the age of 3-4 years old. So whenever I see children who is getting pediatric palliative care, um, it was very difficult for me. So I used to ask my friend to see the pediatric patients. Instead, I will see the adult patients. Um, so after 18 years, when I look back now, we don't have many pediatric patients, but we do get pediatric patients occasionally. But now I do see pediatric patients which do not affect me much. So what I'm telling is that sometimes it will be very difficult for a person to see pediatric patients when they have many factors which relate to the patient. So if you have a team, then it would be okay to transfer your responsibility to somebody. But if you are alone in the team, then it would be very difficult. You have to take the responsibility. There is no choice. So just want to give my or share my experience with you so that you will understand whenever you see a patient like this, what will you go through.
Dr. Sunil and Dr. Theo, I wanted your comments on, have I done right by using the white paper consensus the way I did, or have I done something wrong? I'm very curious to know whether that was a good thing to do.
Yeah, so for pediatrics, so when the white paper was made, I believe it was primarily geared towards adults, right? But when looking at conversions for methadone to morphine, there isn't necessarily anything that's fully established for pediatrics. And even looking at other resources, right? There's still variations on what are suggested. Some people use the older methadone conversion tables where there's the various ratios between doses of less than 100, 100 to 300, and so on and so forth. And then some may actually use conversion ratios similar to the white paper consensus. So I would say what you did was not wrong. And actually, I think the doses that you used were actually quite appropriate. And also when we look at just weight-based dosing for methadone, I think, let me pull up the ratios or the initial doses. Sorry, I'm not super familiar with pediatrics in practice. I always have to look up the doses again. So for methadone, for starting doses for oral, usually the recommended doses is 0.1 mg per kg per dose every 8 to 12 hours. So if we did that in this patient, that would be 0.8. And essentially, we know that this patient was opioid tolerant. So the conversion you did was actually pretty close to the initial dose. And you could have gone a little bit higher too, but from that conservative dose, you found that the patient responded well and had significant improvements in pain. So I think how you went about doing this conversion with methadone was great.
I had used the other ratios earlier when I was new to methadone, and 2019, I was using the tables, depending on the dose of morphine, the 1:4, 1:8, that kind of table. And I found that the titration took very, very long, and the pain relief wasn't, I mean, by the time you get good analgesia, it would be a couple of weeks. I mean, 3 weeks generally. Yeah. So after this white paper consensus, which thanks to I had a sneak session in the previous round of the advanced refresher course. So and when I heard you present the white paper data, it was so helpful. Actually, it has made usage of methadone so practical and so pragmatic, and you can see the result really, really fast. So, I mean, thanks to Dr. Sunil and Pallium India and Dr. Theo for introducing white paper to us.
Yeah, and in regards to other medications that can be used, since the patient had some movement issues or the autonomic movement issues you mentioned with loss with his head, sometimes we could do two is right. You had the patient on gabapentin. Sometimes increasing the dose can help with some of the with that type of pain, but also gabapentin can sometimes help in pediatric patients with autonomic issues too. So dose titration of that could be considered, but some resources that I sometimes go to for pediatrics symptoms is actually from Dana-Farber, which I can add the links onto the chat right now. That way our participants can take a look at that. In regards to the QTC, where that was at, I think what you did was good, just making sure that to minimize any additional contributors to QTC prolongation, making sure that there isn't any unnecessary medications that can increase the QTC, and then other things depending on goals of care, right? If there are labs or electrolyte imbalances, those could be attempted to correct to mitigate some of that risk. But really it's just being cautious. It's, having a QTC between the 450 and 500 isn't a contraindication, just more of a flag for us if QTC monitoring is even within the goals of care for treatment, but it's a flag for us to be cautious.
Yeah. In this patient, I would not be really worried much about QTC interval because the patient is going to die in a few weeks. So even though it is above the normal limit for 60, but I think we can actually give methadone as it is going to help the patient. And as I'm also in concurrence with Dr. Meenakshi that we do not have much opioids for rotation in India, and fentanyl will not be fentanyl patch will not be an opioid which can be used very frequently for many of the patients. So I think methadone and morphine are the two opioids which we can use very freely, but not fentanyl. And I think not only in case of children, but also in case of adults, when the patient is at home, especially, then I think we need to have some anticipatory prescription. So the anticipatory prescriptions are those medications which we expect that this patient can have during the coming days when the patient is going to die. So maybe haloperidol, midazolam, glycopyrrolate, or hyacinth-butyl bromide. These are the usual medication which the patient might need. Haloperidol for excitation if you are anticipating some seizure, or if you are expecting this patient need palliative sedation, then haloperidol and midazolam. And for death rattle, if it is not settling with that gravity assisted drainage, then you need to use glycopyrrolate or hyacinth-butyl bromide. And even we actually teach the caregivers how to administer these medications, and we load the syringe and give it to the caregiver, and we will give the phone number which is available 24 hours. They can call. So that's how we practice or support the patients during end of life. And now we have telehealth, so we are also able to support the patients. Even we can see them and advise the family. And I think a mother, yeah, it's very true that the family members, all the family members, would be having will be having more psychological problems. So. Uh, uh, I think a few weeks back we had a 3-year-old child who had leukemia, and he died in our IP. And when we went for bereavement visit, we saw that the mother is in the room, and there is nobody who is listening to the mother. Mother actually wanted to speak, but whenever a mother is going to talk to somebody, they will suddenly stop the conversation. So she is unable to vent her emotions. So when our team went there and listened to her, that was a relief for the mother. So I think most important thing is always what we think is important is listen to the mother, and address her concerns. Uh, if anybody else has any points regarding on the points which Dr. Meenakshi has raised, please give your comments.
I just wanted to confirm if the participants got the links for the resources to the Dana-Farber Cancer Institute pediatric references. I believe that they're nice and easy to read and go through, and they're free to access on those links.
Thank you for the resources, Dr. Theo. That will be very helpful.
Yeah, and I like this because it also has the weight-based dosing and titration recommendations and initial dose for pediatric patients.
Actually, as of now, we have
anybody
a
has
child.
any more comments on this page?
Madam, what about the feeding part of the baby? Being a child, mother will be anxious, no, about the feeding of the baby.
She was eating fine. I mean, that was never a problem. I mean, when there was no pain, she would eat her meals. She wasn't bothered by nausea and vomiting or constipation, mercifully. So it was only when the pain was becoming unbearable when she would become agitated and start spitting.
Okay.
Otherwise, her appetite wise, she was okay. But towards the end, she will become, I mean, definitely the intake was going down very much and she was very fatigued. And I mean, daytime drowsiness was there. That was the last 1 week.
Okay. Okay, madam. Thank you.
And will this methadone cause more nausea, vomiting than morphine?
Surprisingly, causes lesser.
Okay. And constipation, ma'am?
Lesser than morphine. At least that's what I've observed. I mean, Dr. Sunil and Dr. Theo have more experience. My experience is pretty new with the methadone. So, but that's what I've observed.
Yeah, I think it's almost same as morphine or less than that. Yeah.
Yeah, I would say you would still want to be monitoring for constipation in patients that were putting on methadone, but I wouldn't say that it would be any more. And because there is some reduction of tolerance, right? The overall opioid requirements for patients might be less. So in that scenario, it could help with having less of constipation, but I wouldn't ever rule out or not monitor.
So, Rajlakshmi, can we unshare this screen? Okay, so I think we have 5 more minutes. I think I will just present one patient story, not in a PowerPoint presentation because we don't have time. So this is a patient who I don't know. Mm, uh, sometime you might have had this. I usually say in classes. This is a 41-year-old male with who was diagnosed with retroviral infection, and he was complaining of a particular type of pain from the neck to the neck to the wrist, whole arm. So we know it's a neuropathic pain, but it was not very well responding to the usual adjuvants, and he had actually very severe pain, 10 by 10. So when the patient was started on morphine, we started just on, I think, on 5 or 10 milligram of morphine every 4 hourly. And he was admitted during that time. So he was complaining of abdominal pain after taking morphine. And that was there after each dose of morphine. So anybody has any
Biliary colic?
clues about this?
Biliary colic. Is it some colic like morphine induced?
Dr. Sunil?
Yeah. Can you hear me?
Yes, sir. Audible.
Yeah. Does anybody else has any comments on why this patient is complaining of abdominal pain?
Hello, Dr. Kale here. With the morphine, it causes spasm of sphincter of Oddi, so it can cause pain in the abdomen.
Thank you, sir. I would like to ask another question. How many of you have seen patients having this sphincter of Oddi spasm in a patient who is receiving morphine?
No experience, sir. This is possibility, I said.
Yeah. Even though we know theoretically it can happen, I might have prescribed morphine for thousands of patients, but I have seen this for the first time. So this patient actually will have abdominal pain exactly in the right hypochondrium 20 to 30 minutes after administration of morphine. And when we suspected that this might be due to sphincter of Oddi spasm, then we observed, and each time he had this pain, which will reduce with some anticholinergics. But on tramadol, he was comfortable. But for this patient, we started him on methadone, and he didn't had any sphincter of Oddi spasm. So these are things which we usually maybe it will be there in the textbook, but we usually don't see. And this will be one of a rare patient. I think so. Just want to share with you all this. And another patient, he was on methadone, morphine for pain, patient with the carcinoma of the prostate. And I think he was on 120 milligram of morphine, and he was converted to 10 milligram of methadone. So this patient, and this patient was living with his daughter-in-law, and she was actually giving the medication to him. So we started the patient on methadone on a day, and next day the patient was brought to us. And when we asked, the patient had severe pain. He was drowsy. He had yawning, lacrimation, and nasal discharge. And anxiety, tachycardia. So, does anybody has any clue what is happening to this patient?
Morphine withdrawal.
Some cholinergic overactivity, like.
Okay. Okay. So patient was on morphine, and we converted him to methadone. And next day, patient comes to us with these problems.
So morphine
So
withdrawal.
Sorry.
Morphine withdrawal.
Yeah, this is actually opioid withdrawal. And this patient, when we saw him and understood these symptoms might be due to morphine or withdrawal, then we gave him injection morphine 3 milligram IV. Then patient slept for about 1 hour, and when he woke up, he was perfectly normal. He didn't had any symptoms. So just want to tell you that sometimes this may occur when you convert a patient. We don't know whether this patient has taken methadone after going home properly, and that might have precipitated withdrawal. I am not sure, but just keep in mind this can happen. If some patient comes to you with these symptoms like lacrimation, yawning, drowsiness, anxiety, tachycardia, this might be due to opioid withdrawal. Yeah, and these are, I think, these are two experience which I had during the last 3-4 years with methadone. Theo, do you have any more points?
So then, excuse me, sir.
Yeah.
So then, you restarted morphine, sir, after that, after settling the patient, or how did you
Yes.
manage after that?
Yeah, we restart. Am I audible?
Yes,
No,
sir.
sir.
Audible now.
Audible now,
Lost
sir.
audio.
Yeah. So we restarted the patient on morphine.
So methadone was not continued, sir. Like methadone was stopped.
Methadone was not continued because the family was not willing to try with methadone. They thought it is because of methadone these problems arise. So they were more comfortable with morphine. So we also thought that let him take morphine for.
He was on 120 mg, sir.
Theo, do you have? Yeah, 120 mg.
Okay.
So, I mean, not necessarily any new points, but whenever we do any conversions to methadone, always remembering to allow for SOS dosing for short-acting opioids and for giving education on when to use it and potential symptoms. Like Dr. Sunil mentioned, that could be signs of opioid withdrawals that they can also use their SOS dosing to help relieve, because it may take patients may respond a little bit differently and maybe have higher requirements even with conversions. So that's why we do these conversions and then see what their SOS dose requirements are. I think on the audience, there's a question if methadone can be used if no ECG facility is not available. I think if it's not an option and that is aligned with the patient's goals of care, and there's discussion with the patient to inform them about the potential risk, and the patients have consent, I think that is okay to do. So the biggest thing is making sure that you educate patients and giving them sufficient knowledge.
Thank you, Theo. So I think it's already 8:35. So I think we can wind up the session for today. So I would like to thank Theo for coming and sharing his experience with methadone. So it is always helpful, and thank you, Theo. And I would also like to thank Dr. Shanti and Dr. Meenakshi for bringing up with two patient stories, which I think was very interesting, and it gave a good experience for all of us to understand more about many aspects of patient care. So thank you, and thank you all. Thanks to all of you who participated for this session. So it's over to Rajlakshmi.
Thank you, sir. Thank you, Sunil sir. This is Shripriya. So thank you everyone for joining in, and we do hope that the session was really informative as the chats are coming in. So with that positive note, this is Shripriya along with Dr. Theo and Dr. Sunil signing off from the Clip Psycho Hub. Stay tuned for another interesting session next week with other eminent faculty. Till then, take care. Bye-bye.